Okay, I'm going to go ahead and get started. Welcome and thank you for joining us for the Healthy Living Lecture on Stroke. The program recognizes signs and reduces the risk of stroke. It's been hosted by Henry Ford's Healthy Living Senior Program. My name is Madi and I will be your moderator for today's lecture. I'm the Stroke Program Manager for Henry Ford Macomb Campus. May is Stroke Awareness Month and I'm excited to share this topic with you. This afternoon, you will hear from Dr. Pouya Entezami, a neurovascular interventionalist and a neurosurgeon at Henry Ford Health. Dr. Entezami will provide an overview of the types of strokes there are, signs and symptoms of stroke, and what to do if you think you're having a stroke. We will also discuss treatment options, how to reduce your risk of having a stroke or having another stroke if you've had one in the past. Following Dr. Entezami's presentation, we'll have question and answer sessions, so you will be able to type your questions in the chat box. Please do not share any personal information. And to ensure that we have a smooth experience, please turn off your cameras and reduce any background noise. This lecture is being recorded and will be available to you again in the Healthy Living Lecture series on henryford.com/Healthy Living Lectures. I am happy to introduce Dr. Pouya Entezami.
Thank you, Maudie, for that lovely introduction. This is a topic I'm really passionate about and have spent my life working on. So it's an honor to be able to speak to all of you about this today. My hope is from this lecture, you get a better sense of what signs to look for if a stroke is happening in a loved one, how to reduce your risk of a stroke happening, and ultimately what to do if someone you love or someone around you is having or displaying signs and symptoms of a stroke. Why is this so important? This is a very common problem in our patient population. Every 40 seconds, someone in the United States has a stroke, and the majority of these are preventable, or certainly we can modify the risk of them and try to reduce the chance that you have a stroke. Strokes account for a very high percentage of our mortality. Every 19 deaths in the United States, one of those is caused by a stroke. And as providers, not just myself, but all of our neurologists, our primary care doctors, our internal medicine physicians, and then all of our colleagues who work together always have stroke in the back of our minds as something that can happen to our patients and are working very hard to prevent that from happening, both clinically in how we treat you, the medications we prescribe, and on the other end in our research endeavors. So Henry Ford has a really robust research program that's growing every day, and we collaborate with a lot of centers around the world to bring cutting-edge stroke care to our patients. What is a stroke? This is one of the most common questions, and it's not an easy one to always answer for patients. Really what it is an interruption in blood flow. So that can happen in one of two ways. It can happen when a blood vessel is blocked off. That's called an ischemic stroke. Or it can happen when there's bleeding in the brain due to a ruptured blood vessel, and that's called a hemorrhagic type stroke. We're going to go through both of those today and discuss what that means. So an ischemic stroke, which is the most common kind of stroke, is when a blockage happens in an artery. About 1 in every 10 of these, about 1 in every 10 strokes is caused by a blockage. And so this is the more common type of stroke that can happen. Once that blockage occurs, there's a lack of oxygen that gets to the brain tissue. And all of our tissues in our body, our skin, our muscles, our fat, our organs, they all require oxygen to metabolize and continue to work. So whenever there's a blockage and there's a lack of blood flow to an area, that tissue can die, and our brain's no exception. In fact, our brain is one of the more sensitive areas of our bodies. Whenever those cells die as a result of a lack of blood flow, what you get is a stroke. The other kind of stroke is a hemorrhagic stroke. This is less common, about 1 in every 10 or 13%. This is when the blood vessels that go to a part of your brain to deliver tissue burst. This can happen for a variety of reasons. It can happen due to high blood pressure. It can happen due to an aneurysm rupture. It can happen due to vascular malformations of the brain, which are irregular bundles of blood vessels that we can sometimes see on imaging. There's not a great way to screen for some of these things, so sometimes we really focus on, as a community, reducing everyone's blood pressure, keeping everyone in a safe blood pressure range to reduce their risk of these events happening. When those things happen, then usually a neurosurgeon and an interventionalist is called, and we kind of work together to try and help patients, along with our neurology and intensive care colleagues. And a lot of you may have heard about something called a mini stroke or transient ischemic attack, or TIA. This is not necessarily a stroke technically, but they're usually a warning signs or a herald that you're at risk for having additional strokes. This is a temporary blockage that can happen. So a piece of plaque can block an artery, or a piece of clot from your heart can block a really small artery, and it'll either break up on its own or you'll get blood around it. And that'll prevent the brain tissue there from dying. But it usually means there's a bigger problem that we have to address before you have a larger stroke. So this is not something that should ever be ignored. So what do we do? Let's say a loved one is having a stroke and they come to the hospital. The most important thing for us is time. Time is critical for us. It's crucial. And the type of treatment that we can offer depends on how soon your loved one or you are evaluated. Every type of stroke is an emergency and requires urgent evaluation. And there's an old adage that time saved is brain saved. This is because every minute that you have a lack of blood flow to your brain from a stroke, over 2 million brain cells can die. Now, that varies between each person, but it's quite a lot of brain tissue. So we work really fast to try and reduce the amount of time that damage is occurring because there's a lack of blood flow. So for ischemic strokes, or the blockage type of strokes, someone who's experiencing a blockage in one of their blood vessels may be eligible for clot-busting medications. This includes drugs like TPA and TNK, which are clot busters. They go through your IV, and they, throughout your body, break up any clots that you may have. There's a really small window, and initially when this drug came out, we could only give it for the first 3 hours after symptoms started. So if someone started developing problems at noon, if they were evaluated after 3 o'clock, we weren't able to give it. That time frame has been pushed out further, so now it's about 4.5 hours. And in rare cases, we can go a little further than that. But in general, it has to be a very short time for that drug to be effective for you. There's a lot of things that would prevent you from getting the drug. For example, if you're on blood thinners, which are usually often to prevent strokes, but we don't want to sort of double down and give you an additional blood thinner in addition to the blood thinner you're on at home. So we would generally not give you a clot-busting medication to reduce the risk of you having brain bleeding as a result. If you've recently had major surgery, if you have a hemorrhagic type stroke or the bleeding kind of stroke, generally those patients are not able to receive the clot-busting medications. That's not the end of the road. So since the early 2000s, we started looking at ways to remove blood clots. And as of 2015, it became standard of care to try to remove blood clots from the brain surgically. That's called a thrombectomy. So if you come to the hospital and your scans are favorable, meaning we get scans of your brain and it shows that this procedure would be helpful, we take you emergently as quick as possible to our operating rooms and use catheters that go up from your leg. You can see in this graphic, there's an insertion site in your leg. And then we use a series of wires and catheters, which are like little hollow tubes, to go all the way up from your leg into your brain, go past your heart, go up your arm, up your aorta, and go into your brain. And then we have different devices, including stents and aspiration, which are little suction tubes to pull the clot out and restore blood flow to the brain. Sometimes we can do this even 24 hours after a stroke has started, or sometimes even longer. In some of our newer trials, almost the majority of patients would qualify for this procedure. And the faster we can get to you and get that clot out, the better your chances of recovery are. So that's why when you come to the hospital with a stroke, everyone sort of changes gears and moves much quicker, because we know the sooner we can get to your treatment, the better off you'll be. Now, what if you're not eligible for either of those? So if a patient's not eligible for the clot-busting medication and they're not eligible for a thrombectomy based on our criteria, there's still a very strong role in stroke prevention and treatment. Physical therapy and occupational therapy and our speech therapists will work very closely to help improve the function of our patients who've suffered a stroke. At the same time, our neurology colleagues will work very closely with us to find and identify the reasons you may have had a stroke and to work on preventing additional strokes in the future. That next step in prevention and maintenance to give you the best chance of recovery is one of the most important parts of stroke management. And oftentimes you'll find patients who even come into the hospital very sick can do well over time if they receive the right kind of therapy and preventative measures. What about for hemorrhagic strokes? So those are all the treatment options for blockage type strokes. But what if you've had a bleeding type stroke? The first kind of bleeding type stroke we can talk about is intracerebral hemorrhage. So this is often due to high blood pressure, and high blood pressure can cause the blood vessels to burst. Up until very recently, surgery was not considered to be very effective, but more and more we're doing newer and newer trials around the country and finding there is a role for surgery. So even patients who have a bleeding type stroke may qualify for an operation where we go remove the blood. We're more and more using minimally invasive tube systems, so much, much smaller systems to remove the blood that allow for better results for our patients. We often will reverse any blood thinners you're on. So if you're on a blood thinning type medication, we will give medication to reverse those. And we have newer and newer reversal agents or drugs that can help us in those scenarios. There are some patients who present with a ruptured aneurysm that can cause a bleeding type called a subarachnoid hemorrhage. In those cases, not only do we want to treat the bleeding, but we want to treat the source of the bleeding. And we'll often use either open brain surgery, where we open up the brain and go put an aneurysm clip, which is basically a staple, over the neck or the origin of that aneurysm. Or as you can see in this picture here, we can go inside of the aneurysm and fill it with metal coils. There are newer and newer treatments coming out each day, and at Henry Ford, we're proud to offer all of those options for our patients. And this is a field that grows constantly. So we're always doing research, always finding new ways to help our patients if they come to the hospital with this kind of brain hemorrhage. In patients who have very severe strokes, either a blockage type stroke or bleeding type stroke, sometimes the neurosurgery team will come and will actually open up the skull partly to allow the brain to swell, and that prevents additional damage from the swelling. So there are sort of options even when strokes are very severe to try and help our patients with their recovery. Now, the warning signs. This is often the most helpful part of this talk, is how do we recognize a stroke is coming on? Since it's an emergency type procedure, and these are emergency things, one of the main acronyms we use is be fast. This kind of helps drive the point home that we want to be really quick about how we take care of these things. So the acronym FAST is very helpful for us. F is a facial droop. So if you see someone who develops a drooping of their face on one side, you can ask them to smile. If their smile is symmetric, it's less likely that it's a stroke, but if they can't move one side of their face, it oftentimes is a sign that they may be having a stroke. A is arm weakness or numbness on one side. You can ask the person you're worried about to raise their arms. If they're unable to raise one of their arms, that can often be a sign that they're having a stroke. Numbness as well and leg weakness are other things you can look for, but for the purposes of this acronym, A is for arm weakness. S is for speech, so speech troubles. If you find that someone can't get words out, can't understand you, or they're beginning to slur their words to the point where you can't understand what they're saying, those are also symptoms of a stroke. Oftentimes it's helpful to ask the patient or the person you're worried about to repeat a sentence. I like, "It's a bright and sunny day in Detroit," but you can use whatever sentence you want. And the T is time. So if you suspect one of these things to be true, you're looking at someone and they all of a sudden have a drooping of their face, time is important. Call 911. We really recommend you don't drive the patient to the hospital yourself, because the EMS team or our emergency responders, our ambulance responders, our firefighters, they can recognize these signs very quickly and can often give us a heads up on the phone. Hey, I have a patient coming in with a concern for a stroke, and we can often take them right to the scanner or even directly to the operating table if we have a very high suspicion, and try to get them evaluated quickly. If it's very concerning, we can often save a lot of time with the right proper steps in place. And our providers in this area are very, very good at catching these strokes, and we can often save a lot of time. Other symptoms that can happen as a result of a stroke are sudden onset of numbness or weakness of the face, arm, or leg, especially if it's on one side. If all of a sudden someone's right leg stops working, that can be a very clear sign that they're having a stroke. If they're having a lot of trouble understanding or they look confused, if they're trouble seeing out of one eye, that can be a stroke that can occur in the back of your brain. It's less common, but it can happen. If they're having a lot of trouble walking or uncoordinated all of a sudden, if they were walking fine 20 minutes ago and all of a sudden they can't maintain their balance, that can be a sign of a stroke. And for bleeding type strokes, if a patient all of a sudden has a sudden severe headache, the worst headache they've ever had, that can be the sign that they've had a hemorrhage in their brain. Now, I don't want everyone to get worried every time they have a headache, but if it is the worst headache you've ever had and you've never experienced anything like that, it's different from your other headaches that you've had throughout your life, those are signs and symptoms that you could be having a stroke and should be evaluated. How do we reduce our risk? These are things I think about all the time, and how do I reduce my own risk of stroke, and as well as my loved ones. So am I at risk? This is stuff we can't change. Certain things we have no control over our age. So our risk of having a stroke doubles for every decade of life after the age of 55. A stroke is much more common in someone who's in their 80s than in their 50s. Family history, we can't change the family we're born into. Patients who come from a family where there's a high risk of stroke have a higher risk, almost twice as high as those who don't have a family history of stroke. Race, our Black American patients have a much higher risk of stroke, and also death from a stroke. This is multifactorial. It's not just the race, but it also has to do with disparities in healthcare equality and the way we deliver healthcare, and it's something we're actively looking at. But there is a higher chance of stroke in our minority populations. And women suffer stroke at a much higher rate than men, and stroke more often kills women than it kills men. So there are certain things we have no control over, but do increase our risk of having a stroke, and we should be aware of. However, there are other risk factors we can modify, and this is the other 4 out of 5 patients. So 80% of strokes can be, the risk of a stroke can be reduced in 4 out of 5 patients by lifestyle changes and working with your primary care doctors to control the conditions that can raise your risk of having a stroke. So there are 8 things we wanted to focus on today, which is the Life's Essential 8. And this is a tooltip designed for you to focus on things you can modify in your life to help improve not just your stroke risk, but risk of heart disease, diabetes, a lot of different things. So eat better, whole foods, kind of avoid processing foods as much as you can. Eat a lot of fruits and vegetables, lean proteins, nuts, seeds, and then minimizing your risk of oils when you're cooking can all help reduce your risk of having stroke or other healthcare issues. Increasing your activity. If you can increase your activity to 2.5 hours of moderate or 75 minutes of vigorous physical activity per week, it's not all in one sitting, it's over the whole week, you can significantly reduce your risk of having a stroke. So that means 30 minutes a day, really, of moderate activity, which can be walking. So just getting up and getting moving can be very helpful in reducing your risk of having a stroke. Managing your blood sugar for our diabetic patients or patients with diabetes, working very closely with your primary care doctor, internist, or endocrinologist to reduce your high blood sugar. And if you are diabetic, to monitor your hemoglobin A1C to maintain it in a good range. This can be really, really helpful in reducing the damage to your blood vessels and reducing your risk of a stroke. Managing your weight. We all could use a little bit of weight loss, but we think of an optimal BMI as 25. We know that increasing a BMI above that, or your body mass index, can increase your risk of a stroke. Now, it's not just about losing 100 pounds. Even small changes in your weight can have very long-lasting effects, not just on your risk of a stroke, but of your back pain, your joint pain, other things. So we have a very strong group who works on weight loss here at Henry Ford, and your primary care and internist can get you tied in as we have more and more options to help our patients lose weight. Cholesterol. So there's good cholesterol and bad cholesterol. Having high levels of the bad cholesterol can lead to not just stroke, but also heart disease. So we have a lot of medications. Actually, some of the most commonly prescribed medications are medications used to lower cholesterol. A lot of people are on these, and keeping a low level of the bad cholesterol in your body, both through diet, exercise, and lifestyle modifications, in addition to medications, can very heavily reduce your risk of stroke. In fact, this is one of the really key points we focus on when we're working on prevention for our stroke patients, for future strokes. Managing your blood pressure. Keeping your blood pressure in a good range is really important. The numbers have come down quite a bit in terms of what we consider high blood pressure. When I began my training, we thought of high blood pressure as above 160, now really above 140, which is the top number. When you get your blood pressure, there's two numbers. There's the systolic and the diastolic. Once the systolic is above 140, we start to worry that you have hypertension or high blood pressure. And the diastolic really above 90, we get worried that you have high blood pressure. So keeping really close tabs on your blood pressure, working with your primary care to stay in a healthy range is very important for preventing strokes, especially bleeding type strokes. Smoking cessation, so not smoking cigarettes or other types of tobacco. Especially now with the advent of e-cigarettes and vaping, which are as bad, if not worse, for you. These are some of the most preventable causes of death in the United States. Again, this extends beyond just stroke. It includes heart disease, cancer. But cigarettes are often one of the worst things you can do to your body, and trying to work on quitting that is very helpful. Now, I always tell my patients I'm not likely to get them to quit cold turkey, but there are both medications, patches, gums, and other therapeutic things we can do to help you. If you work really closely with your primary care doctor or internist, they can help guide you towards quitting smoking. And healthy sleep. So this ties into stress a little bit. So high levels of stress, not sleeping enough, are really detrimental for us. A lot of us have jobs where we can't sleep 8 hours a night, or like myself, have a newborn baby at home. So keeping our sleep protected as much as we can, is really important for stress prevention. So most adults need about 7 to 9 hours of sleep. It's a lot more than you think you need. And as we get older, our sleep time actually increases for a lot of patients. So maintaining good sleep habits, not falling asleep with the TV on every night where you inevitably stay up till midnight. Good sleep, we call it sleep hygiene, but getting off your phone once it's bedtime and trying to protect that important sleep time is very important for your health, both for regenerating yourself from the trauma of the day. Even when you're exercising heavily, if you're not sleeping right, it doesn't matter. You really need to kind of combine all these things to achieve good lifestyle modifications. So if you're exercising really hard, but you're not giving your body a chance to rest and recover your muscles, it's not going to be effective. So we really recommend good 7 to 9 hours of sleep for our patients. I wanted to make a note about atrial fibrillation or AFib. A lot of patients have this. This EKG strip, which is a heart rhythm strip, shows a normal rhythm here in the top strip. In the lower strip, you can see there are some irregularities in the sawtooth, or those bouncing waves. And that can represent something called atrial fibrillation. When your heart's beating irregularly and not clearing the chamber of the heart every time it beats, you can develop clot, and that can sort of break off and get into the brain tissues, cause strokes. It's a very common cause of stroke. So atrial fibrillation is a disorder of the rhythm of the heart. And we have both medical options on how to fix this, which include blood thinners on one end to keep your blood nice and thin and prevent clot formation. And on the other end, include medications to try and control the rhythm. Having atrial fibrillation that's untreated and unmanaged can increase your risk of stroke to up to 5 times a normal person without those cardiac abnormalities. In addition to that, our cardiology colleagues have newer surgical treatments to try and control atrial fibrillation. And so we work very closely with our heart doctors to try and reduce the risk of stroke in our patients who have atrial fibrillation. And then carotid artery disease. So carotid artery disease is a disorder of the blood vessels of the neck. So if you gently put your hand on your neck, you can often feel a little bounding pulse. That pulse is your carotid artery that takes blood from your aorta all the way up to your head. This can be a source of very turbulent flow and a lot of pressure because all the blood going to your head, which is a lot of blood every second of every day since you've been born, can put a lot of pressure on this area. If you have high cholesterol and high blood pressure, it can start to calcify and become hard. When that happens, it can become narrow. It's just like plumbing. If you have tubes in your house, and they start to build calcium up on the inside from hard water, it can restrict the blood flow and ultimately lead to a stroke. It can also lead to plaque breaking off and going to your brain. Or it can ultimately become blocked in the neck. And that's a fairly dangerous type of blockage because there's nothing else that then is getting to your brain to help keep the brain tissue alive while we get you to surgery. Oftentimes, patients who have disease in their carotid arteries, and we have very strict guidelines on how this is done, are managed either with a carotid endarterectomy, where we make an opening in your neck and remove the plaque, or sometimes with a stent, where we put a stent on the inside and pop the artery back open. There's reasons we do either one, but once you are diagnosed with carotid artery disease, generally our vascular surgeons, neurosurgeons, neurologists, interventional radiologists, and cardiologists all work together to find the best treatment option for your particular case. In fact, every Friday we have a board of specialists in this area who we all sit together and discuss our carotid cases and find the best treatment options for our patients, for each particular patient. Tips for a healthier lifestyle, like we talked about today. Take your medication as directed. If your primary care thinks your blood pressure is too high or your cholesterol is too high, they're generally trying to prevent not just strokes, but a lot of different healthcare issues. And working with your primary care doc and your internist to take those medications as they're directed can be very helpful in reducing your risk of stroke. Getting your blood pressure checked regularly is very important. Blood pressure is one of the leading causes of strokes, and maintaining a good blood pressure is very important for us. Keeping your stress levels low is not always possible, but it's important to try and maintain an even keel. We all have stresses throughout our day and our lives, but we want to manage these as best as possible. Seeking emotional support when it's needed can be helpful. And as you go through these healthcare journeys and try to achieve a healthier lifestyle and reduce not just your risk of stroke, but heart disease and other problems, ask your family and friends to support you. So if you want to make a lifestyle change, such as not smoking, ask the people around you who do smoke to not smoke around you. That can help you achieve your goals and also may encourage them to try to make changes as well. And then make sure you check in with your doctor regularly, at least every year as we get older. But certainly if you have medical issues that warrant closer follow-up, making sure you stay on top of those over time can be really important in staying out of my operating room. And that's what I want for all of our patients, is that ultimately my hope is down the road, I'm not needed anymore. And people aren't having strokes at the rate we're having them right now. So our stroke centers, we have across our 5 Henry Ford Health hospitals and our ERs and urgent cares, we have a team of stroke experts. All of us actually collaborate via our phones and have a system-wide set of apps and tools where anyone who's evaluated in a Henry Ford hospital for a stroke, their scans are uploaded so that the stroke specialists can evaluate them, determine where they should go or what surgeries or treatments they should have, whether it's medication or the thrombectomy procedure, foiling, clipping, surgery beyond that, whatever is needed. All 5 of our hospitals are at the very least primary stroke centers, and this includes going up to the highest level of care, which is the comprehensive stroke center we have downtown at our hub in Detroit. Our West Bloomfield campus is thrombectomy capable, and our Macomb campus is soon hoping to be thrombectomy capable as well. And thrombectomies can be performed at downtown in Detroit, at West Bloomfield, and at Macomb Hospital. but we sort of collaborate between all of us. So if you're triaged or seen at any of our hospitals, we sort of direct you to the most important, kind of closest center for you to receive care. And then outpatient follow-up for our post-stroke and stroke prevention patients. So patients who've had a stroke or are in the follow-up period or in the prevention period. We have centers throughout Southeast Michigan and including in Jackson and Central Michigan where this can be done with a very, very capable and powerful team of neurologists who really drive the ship for us. We have inpatient rehabilitation for stroke patients at both Wyandotte and Macomb. And we have a very strong team of physical therapists, occupational therapists, and speech therapists at all these locations. And that can be really a powerful tool and important in the recovery of our stroke patients. There's a website here, henryford.com/stroke, that can give you a little more information about the services we offer. And in closing, stroke is a brain attack, which is a disruption in the blood flow and oxygen delivery to the brain tissues. This can happen to anyone at any age and at any time, though it's certainly much more likely as we get older. 2 million brain cells die every minute you're having a stroke, and so speed is critical. Getting to medical treatment right away is really important. There are medical treatments that can reduce the effects of a stroke if they're administered quickly enough. So that includes getting to the hospital and getting evaluated and getting the treatment started as soon as possible. Remember the FAST acronym. Face, so facial droop, arm, or arm weakness. S for speech, or trouble speaking, repeating words, or even responding. And T is time, so making sure you call 911 as quickly as possible. And in a lot of patients, that stroke can be prevented. So put some time aside here for questions. So I will pull up our questions now. And I'll try to go down in the order that I've received them. So are there tests available to diagnose CAD and AFib? So coronary artery disease is CAD. There's also carotid artery disease, which can also be CAD. So back in the day, we used to check for bruits. So your primary care can put a stethoscope on your neck, just like plumbing. If it starts to whistle when it's narrow, your carotid does the same thing. So we can often hear those. There are non-invasive tests such as ultrasounds, or we can use an ultrasound probe to check the degree of narrowing in your neck. So those are 2 screening tests that can happen. Often high-risk patients will be sent for screening. So if your primary care doc feels that you're high risk for that, they can send you for a non-invasive test and check you for any narrowing in your carotid arteries. As far as atrial fibrillation goes, that can often be diagnosed with, if you're actively in atrial fibrillation, it can be diagnosed with a rhythm strip. So they'll put leads on your chest wall, and that can actually detect the rhythm of your heart, and that will tell you if you have atrial fibrillation. Other patients we think are high risk for having atrial fibrillation based on their symptoms, they can have a loop recorder placed. So they can actually have a recorder placed under their skin that records their heart over time. So if you're not in AFib at the time, but you have symptoms of AFib, we can sort of detect that down the road and keep a close eye on it. So yes, for both of those things, we have both non-invasive and invasive tests depending on your risk factors. Next question is, are people with non-arteritic ischemic optic neuropathy at high risk for stroke? Ischemic disease of any blood vessel in your brain and your nervous system does increase your risk of stroke overall. We really want to, one of the main heralds, and this is a great question by Mary, is vision loss in one eye. So we talked about TIAs as being a herald for stroke, but retinal artery occlusion oftentimes is another sort of TIA type symptom that's missed. So patients with temporary vision loss that either goes away or doesn't, we really want to make sure we check their carotid to make sure they don't have carotid disease that caused plaque to go up into the eye. So the ophthalmic artery, which is one of the first arteries off of your carotid artery to go to branch out, it goes to your eye, and so that can be a herald of strokes to come. So we want to make sure we keep an eye on that. So Ms. Tina asked, is it best to take the blood pressure medication the nighttime or the daytime? That really depends on which blood pressure medication you're on. Certain medications, especially when they're once a day, are often taken in the morning. And then their effect lasts for 24 hours. Other medications, the effect lasts for 12 hours only. So you need to take it twice a day. In general, I think when you're on multiple, especially if you're on multiple medications, it's important to coordinate those so that I think it's often helpful just to take them at one time so you don't forget any. So if you're only on one medication for your blood pressure, it should last 24 hours. So our goal when we prescribe blood pressure medications is that they control your blood pressure throughout the day, not just for 12 hours. So if you're on a once-a-day medication, it's generally a long-acting medication and can work throughout the day and night. But that's something that I think your primary care will usually work out with you so that if you're, for example, if you have a medication you're taking separately, it's only at night, that you can usually take your blood pressure medication then too. Certain other blood pressure medications that have more of a rhythm effect, we want to oftentimes take those more than once a day, depending on the duration of their action. So we want to really work closely with your primary care doctor to find the optimal timing for your medications. Is there another run at this? I believe this is going to be recorded and then shared both on Facebook and then in the Healthy Living Stroke series, in the Healthy Living lecture series from Henry Ford. So I believe all of this has been recorded. So if you wanted to watch it, or a friend or colleague wants to watch it later on, they're absolutely able to see that. They say most strokes happen when you're asleep. So strokes can happen both when you're awake or when you're asleep. So I don't know if most strokes really do happen when you're asleep, but we're finding more and more that the strokes that we can prevent are often found during the day because you're awake when it happens. Now, that being said, there was a trial in the past few years called the Dawn trial that even when a stroke happens when you are asleep, we can still take you to surgery and try to fix it and reduce your damage and give you the best chance of recovery. When you do fall asleep, oftentimes your blood pressure will decrease because you're not stressed, you're not awake, you're not actively engaging activity. And so for some patients, that drop in blood pressure, if they have narrowing of the arteries in the brain, can cause a stroke. But in general, strokes can happen anytime. See our next set of questions. How does COPD factor into stroke? So COPD is chronic obstructive pulmonary disease. In general, COPD, patients who have COPD have a lack of oxygen delivering capacity. Their lungs are not able to exchange oxygen at quite the same rate. And so a lot of patients with COPD either are on oxygen at home, meaning they walk around with a can and have oxygen being delivered into their bloodstream. So those changes in your oxygenation of your blood can certainly in some patients increase their risk of stroke. So if you're relying on a really thin artery, meaning your artery has a lot of plaque built up on it, and the rate of oxygen delivery when you're 60 and have COPD compared to when you were 20 and maybe a little bit healthier, there's kind of a lack of blood flow that can happen. And so when your oxygen saturation or that percent of oxygen in your blood goes down, you may be at higher risk of stroke. Now, the other thing that can happen is when you have COPD, you will often develop other issues in addition. So you can develop heart disease, increase in atherosclerosis, or kind of calcifications in cholesterol, and all those things sort of compound onto each other. So just COPD on its own doesn't necessarily increase your risk of stroke, but it's kind of the state of health you're in around that that can be a problem. And so, if you have COPD, really working closely with your pulmonary doctors to maintain as good of pulmonary health or lung health as you can, and staying as active as you can, because oftentimes our COPD patients tend to be less active as their lungs may not allow them to, say, go on a longer walk. So that can definitely play a factor. So we want to keep really close tabs on our oxygenation. Is stroke risk hereditary? So patients who have a family history of stroke will have a nearly double risk of stroke in themselves. So if you have a family member, such as a parent or grandparent who had a risk of stroke, your risk factor is automatically higher. Now, we don't know if it's causative. We just know that when we look at populations, that can happen, whether it's a genetic factor Or, for example, if diabetes runs in your family, we know that if you've had a family member with a stroke, a direct family member, then your risk is higher too. So for patients who have a family history of stroke, those lifestyle modifications, those 8 things we talked about, are even more important. I'll give a few more minutes to see if there's any other questions. And I really thank you all for joining us today. And I hope you never need me, but Henry Ford is really starting to, not starting to, but really progressing the amount of research and work they're putting in to help our stroke patients. The hospitals in this area, other than Henry Ford, are also really motivated and driven to help our stroke patients and keep our population healthy in Southeast Michigan and beyond. So it really means a lot that there's an interest in the community, and I hope it's been helpful.
Thank you, Dr. Entezami. The information you shared was very informational. I also wanted to just kind of give a shout out to our stroke survivorship group through Henry Ford. Anyone who's interested in that, or if they have family members who are interested in joining this group, they can go to henryford.com/stroke and then just look into the resources. We'll have a stroke navigator can call you and help you set up some of those meetings or let you know where they're at. One exciting thing that we do here at Macomb, a little bit different, is that we collaborate with Disability Network, and we've been able to have stroke survivors do things like adaptive golf. So for those hands that are, if they're hemiparesis or hemiplegic, they also had adaptive kayaking. They do lots of yoga and cooking classes, stroke comedy. So lots of good things that we're doing for the stroke community after they are discharged from our facilities. So just look that up, henryford.com/services/stroke.resources. If you have any other questions, feel free to reach out to any one of the nurse navigators or the stroke program coordinators, and we'll be happy to hook you up with any of those resources that you might need. And just another plug here, we will be having our American Heart and American Stroke Association walk coming up on June 8th. So there's still time to register, and it's for a good cause. So make sure that you get entered into that. So also, quick question, I'd like to see any response that something that you learned from this topic and informational lecture was FAST. So do we remember what FAST stands for? And if you do, please just type it in the chat. And thanks again. We're collaborating with the Henry Ford Healthy Living Lectures.